Welcome to the pharmacology class, and today's topic is adrenergic antagonists. And to better understand adrenergic antagonists and drugs that have a antagonistic action, I prepared a special diagram for you. So this is a picture that explains the mechanism of action of adrenergic antagonists. So this is a noradrenaline, that is a sympathomimetic uh, agonist, and this is adrenergic receptor, this white uh, uh, net with the gates, and then uh, this agonist goes here, and then this is a adrenergic antagonist that prevents noradrenaline from reaching the adrenergic receptor. So this is a very useful picture for you to understand how the drugs that have antagonistic activity or prevent the agonist from acting on the receptor. In that case, it is not adrenaline, and the receptor is adrenergic. So almost the same happens here, but so this is a agonist, this is a receptor, and this is antagonist. So actually, antagonist is from Indiana here. These are the uh, drugs that block the adrenergic receptors, and adrenergic receptors are divided into two families, alpha and beta, and that is why the adrenergic antagonists are also divided to alpha blockers and beta blockers. Alpha blockers include the phentolamine, phenoxybenzamine, and also selective alpha 1 prazosin, terazazine, and doxazazine, and also selective alpha 1A tamsulazine, and alpha 2 yohimbine. So beta blockers are also very useful drugs, and also divided to the non-selective, like the propranolol, and selective uh, beta 1 blockers, including metoprolol, atenolol, and many others. So also there are some non-direct acting uh, adrenal blockers, that is reserpine. However, it is seldom used now because of the availability of more effective drugs with the less adverse effects. But still, there are uh, adrenergic blockers that will inhibit the release of the norepinephrine, and that will make the transmission less, and then usually leads to the uh, antagonistic action. And uh, uh, there are different actions on the alpha and beta uh, uh, receptors, and uh, if we uh, if we uh, try to measure the effect of the antagonist itself, we will not find any effect. That is why we need an agonist to see the contraction. So and here we can see the action of the beta agonist isoproterenol, and this is a action of the isoproterenol on the at the blood pressure without any antagonist. So, and if we add an alpha blocker and measure the same, and we then inject the same uh, isoproterenol, then there will be no any effect of the alpha blocking agent to the action of the isoproterenol, because isoproterenol is pure beta uh, adrenergic. So that is why these and these actions are identical. But if we add a beta blocker, then the beta blocker will almost completely antagonize the action of the isoproterenol, because isoproterenol is pure beta adrenergic. So then if we look at the action of the epinephrine will increase and then decrease the uh, blood pressure. So this is a alpha component and this is a beta component. So, and if we block alpha component, then we only see beta part of the action of the epinephrine, and if we block a beta component, we will see only alpha component of the epinephrine. So that is why the blood pressure will increase or decrease. So decrease is a beta component, and then the increase is the alpha component, because alpha receptors are, are located in the vessels, and while stimulating they lead to the contraction of the smooth muscles of the vessels, so that will increase the blood pressure. And if we take a norepinephrine is mostly acts on alpha, and that is why the alpha blockers will block the action of the norepinephrine almost completely, while the beta blockers will not change the action of the norepinephrine, because there is no beta component here. And adverse effects of the beta blockers as well as alpha blockers uh, include the orthostatic hypotension, and that is a common adverse effect for most of the blockers, most of the adrenergic blockers. And then tachycardia, dizziness and headache, and sexual dysfunction are most common side effects. The tachycardia is mostly reflectory, because of the sudden drop in the um, blood pressure. And the orthostatic hypotension is also because of the drop in the blood pressure, especially in older patients. That is a problem mostly with the old patients. And so it can also lead to the syncopes and loss of the and syncope and fainting. So so these are actually the alpha blocking agents, and there is a yohimbine, that is a selective alpha 2 blocker, and it's obtained from the bark of the yohimba tree, and it has been used as a sexual stimulant and in the treatment of erectile dysfunction, but it's not recommended to use it for treatment of these disorders, because of the efficacy is not proven in clinical trials. So Joachim Bean acts on the central nervous system and increases the sympathetic outflow to the periphery, and that is why it's contraindicated in patients with cardiovascular diseases, psychiatric diseases, and also patients with renal dysfunction. So the beta, so the next part of the drugs, or the next family is beta blocking agents or beta adrenergic blocking agents, and most of the useful drugs are beta blockers, and all of them are competitive antagonists, and there are non-selective beta blockers that will act on both beta 1 and beta 2. So beta 1 is in the heart, and beta 1 blocking will decrease the heart rate, and beta 2 is in the bronchioli that will lead to bronchoconstriction, and also in the peripheral vessels that go give blood to the skeletal muscles, and that will lead to the constriction, because stimulation will lead to relaxation, but blocking will lead to the constriction. And also beta blockers will increase the sodium retention and lead to the edema. So these are the actions of the propranolol. Actually, propranolol is a non-selective beta blocker. So beta blockers decrease the blood pressure, and they don't induce much orthostatic hypotension or postural hypotension. So, but still, there may be also a orthostatic hypotension, but less than with the alpha blockers. And the vascular tissue will retain the sympathetic control, and that is why the blood pressure will not decrease much. So, and beta blockers are indicated for hypertension, angina, arrhythmias, myocardial infarction, heart failure, hyperthyroidism, and glaucoma. For the glaucoma, they are used as eye drops and instilled locally, because the effect of the systemic beta blockers to the eye is negligible. And sometimes they are also used for prophylaxis of the migraine headaches. So all beta blockers have a name that ends on all, so most of the beta blockers have all at the end, like metoprolol, atenolol, pindolol, propranolol, timolol. So carvedilol and labetalol, they have alpha 1 blocking components, so that is why they have a different ending. So propranolol is the prototype of the beta adrenergic antagonist, and so this is the first drug that was discovered, and actually the Nobel Prize was awarded for this discovery of the propranolol, and it blocks both beta 1 and beta 2 receptors, and that is why it's non-selective, many side effects, contraindications, asthmatic patients, and diabetic patients. of propranolol will decrease the cardiac output, and that because of the action on the sinoatrial and atrioventricular nodes that are inhibited, and that results in bradycardia, and that is why on the dose of the drug is should be low. Uh, the blockade of the beta 1 receptors decreases the oxygen consumption, cardiac output, and the cardiac load, and that is effective in the treatment of the angina. The beta blockers are also effective in uh, supraventricular cardiac arrhythmias, but they are not effective against the ventricular arrhythmias. So, for the ventricular, usually the lidocaine, so the sodium channel blockers are more effective. But we will get to that later, next year. So, the non-selective blockade of beta receptors also prevents B2 mediated vasodilation in skeletal muscles, increasing peripheral vascular resistance. And the reduction in cardiac output produced by beta blockers leads to decreased blood pressure, which triggers a reflex peripheral vasoconstriction that is reflected in reduced blood flow to the periphery. In patients with hypertension, total peripheral resistance returns to normal or decreases with long-term use of propranolol. There is a gradual reduction of both systolic and diastolic blood pressures in hypertensive patients. In the lungs, blocking beta-2 receptors leads to the contraction of the bronchial smooth muscles in asthmatic patients, and that can lead to the uh, uh, precipitation of the uh, asthma attack or the attack of the chronic obstructive pulmonary disease. That is why beta blockers are contraindicated in patients with chronic obstructive pulmonary disease or asthma. The blockade of the beta receptors leads to the decrease in gluconeogenolysis uh, and decrease glucagon secretion. Therefore, diabetic patients receiving propranolol uh, require careful monitoring of blood pressure because the hypoglycemia may occur after insulin injection. Uh, so, and beta blockers also attenuate the normal physiological response to hypoglycemia. So, decreased gluconeogenolysis. So, gluconeogenolysis is the synthesis of the glucose from the non-glucose uh, uh, reserve in the body. So, usually in the liver. Then, the beta blockers will also block the action of the other agonists, beta agonists, like isoproterenol and uh, other uh, uh, beta drugs that can act on the heart or the uh, uh, or the smooth muscles of the bronchioli. So, for example, the epinephrine will not lower the blood pressure or stimulate the heart, but the it will constrict the blood vessels, and uh, like here the epinephrine will uh, will increase the blood pressure, but norepinephrine will actually act the same because there is less beta component. So the propranolol is indicated for hypertension, and uh, it will not reduce the blood pressure if the blood pressure is normal, but in hypertensive patients, the propranolol will reduce the blood pressure by decreasing the cardiac output, that is primary mechanism of action, and also it will inhibit the renin release from the kidney that will increase the total peripheral resistance after long-term use, and also it increases the sympathetic outflow from the central nervous system that uh, will contribute to the antihypertensive effect. Also, propranolol decreases the oxygen requirements of heart muscle and therefore is effective in reducing chest pain on in patients with angina. Propranolol is used for that, and other beta blockers are used for the treatment of the stable angina. The third indication is myocardial infarction, and propranolol is has a protective effect for the heart. That is why after the second heart attack, the patients use beta blockers, and administration of beta blocker immediately following a myocardial infarction reduces the infarct size and hastens recovery. Uh, the mechanism for this effect is the blocking of the actions of circulating on catecholamines, which would increase the oxygen demand in an already ischemic heart muscle, and propranolol also reduces the incidence of sudden arrhythmic death after myocardial infarction. Propranolol is effective in reducing migraine episodes when used prophylactically. It is one of the more useful beta blockers for this indication due to its lipophilic nature that allows it to penetrate the central nervous system. Uh, so the propranolol is also effective in uh, reducing the sympathetic stimulation, for example, the one that occurs during hypothyroidism, like acute hypothyroidism or thyroid storm, may save life uh, and protect from the cardiac arrhythmias. Propranolol is absorbed uh, after oral administration, and after the first pass metabolism, 25% is reaches the heart, and then it has a large volume of distribution, and it enters the central nervous system because of the high lipophilicity, and it's metabolized and excreted by the urine. Adverse effects include uh, fatigue, bronchoconstriction, sorry, that is not here, but sexual dysfunction. Yes, here is fatigue, bronchoconstriction, sexual dysfunction, and arrhythmias. Arrhythmias usually occur when the drug is stopped abruptly, so the withdrawals should be slow during the 2 weeks or up to 1 month. So bronchoconstriction is the one of the most significant side effects and can lead to the death by asphyxiation in patients with asthma, and that's why it's contraindicated in patients with in asthmatic patients. Arrhythmias can also be life-threatening. Um, that is why treatment with beta blockers must never be stopped abruptly because of the cardiac arrhythmia risk. The beta blockers must be tapered off gradually over a period of at least a few weeks. Long-term treatment with the beta blockers leads to upregulation of the beta receptors, and when the therapy stops, the increased receptors can worsen angina or hypertension. Sexual impairment can be seen in males because uh, ejaculation in males is mediated through alpha adrenergic activation. Beta blockers don't affect the ejaculation or internal bladder sphincter function. On the other hand, some men complain of impaired sexual activity, and the reason for this is not clear and may be independent of the beta receptors. So the sexual dysfunction was actually the side effect of the alpha blockers, but for some reason it's seen in beta blockers too, despite that there are alpha receptors in the bladder. So then there are two other adverse effects. One is the metabolic disturbances that seen in the patients with diabetes uh, because of the decreased gluconeogenesis, and then there are some central nervous system effects including the depression, dizziness, fatigue, weakness, and visual disturbances, hallucinations, short-term memory loss, emotional lability, vivid dreams, including nightmares, and depression. So this the uh, the less is lipophilic the drug, the less central nervous system side effects may be seen. For example, atenolol will cross the blood-brain barrier less, and that is why less central nervous system side effects. Beta blockers are also interfere with the metabolism of the drugs, including the uh, fluoxetine, paroxetine, cimetidine, and they also may potentiate antihypertensive effect of the propranolol and uh, uh, the drugs that increase or decrease the activity of the liver enzymes will also interact with the beta blockers and decrease the effect of the beta blockers. Uh, the non-selective beta antagonists, timolol and nadolol, are used in ophthalmology, and nadolol has a long duration of action and the uh, timolol is used to reduce the production of aqueous humor in the eye, and it is used topically in the treatment of chronic open-angle glaucoma and also for the treatment of the hypertension. Uh, when applied topically on the eye, timolol and betaxolol and carteolol are effective in diminishing intraocular pressure in patients with glaucoma. This effect occurs by decreasing the secretion of aqueous humor by the ciliary body. Unlike the cholinergic drugs, these agents neither affect the ability of the eye to focus for near vision nor change pupil size. So, and then the uh, onset of action is 30 minutes and effects last for 24 hours. That is why beta blockers are used for the chronic management of glaucoma and not for the acute attack of glaucoma, because pilocarpine is drug of choice for the acute attack for the emergency lowering of the intraocular pressure, because pilocarpine is also effective in both types, open and closed angle glaucoma, but the timolol and other beta blockers only effective for the open angle glaucoma. So I think that is all for today, and thank you for your attention, and see you next week.